thank you all for joining us for this Life and Health Talk. I'm Nadia Sharbi, and it's my great pleasure to be your host today. Now, as you know, the theme for today's event is healthcare access for disadvantaged and underserved populations, bridging the gaps. And certainly as the coronavirus pandemic continues to sweep the globe, countries today, rich and poor, have been clashing over unequal vaccine distribution. Now, with this crisis, the existing gaps in healthcare access among and within nations have truly been thrust into the spotlight, hopefully with the effect of sparking some much-needed soul-searching. Now, to help us understand what's at stake and how to tackle these issues, I'm honoured to be sharing this platform today with 5 special guests. Each one plays a crucial role in the effort to bridge the gaps and enable healthcare access for disadvantaged and underserved populations. They'll be taking us through their own experience, giving us their insights, and tell us the stories of those they try to support and serve. So without further ado, let me briefly introduce you to our international panel. Joining us first remotely from New Delhi, we have Dr. Niti Pal. Hello, Niti.
Hi there. Hi, how are you all?
Good. Thank you very much for being with us today. And we can cross over now to Istanbul, where Dr. Serap Aksu is standing by. Serap, hello.
Hi, Nadia.
Thank you for being with us also. Joining us from Dakar is Dr. Kanta Malam Kanta. Hello to you, Kanta.
Hi, everybody.
Thank you for being with us today. Over in Austin, Texas, we have Wesley Dukalski, who's on hand for the US perspective. Wesley, hello.
Hello.
And last but by no means least, with me in the studio, I'm not alone today. In Paris, I'm joined by Elena Graf. Elena, hello. Thank you for being with us.
Hello.
Now, of course, I'll be going into each of your careers and approaches in more detail as we get talking. But I'll start with you, Niti Pal. You're the Senior Advisor for Digital Health at AXA Emerging Customers and Medical Director at KPMG Global Healthcare. You're also practicing GPA in the UK, and you have amazing experience across many health systems, rich and poor. So let me open this talk with a question on your experience. As I mentioned, COVID has exposed the gaps in access to care. Could you tell us a bit about the challenges you've witnessed regarding disadvantaged and underserved populations during this particular crisis?
So it's been a very interesting journey, this pandemic, and I called it when 2 pandemics collide. So what we've seen is chronic diseases relentlessly on the rise, not just in poor and underserved communities, but just everywhere. And then we've seen this pandemic, this infection sweep across the world. So what we've seen is that poor and disadvantaged communities have taken a bigger hit. They've been more sick to start off with. So we've had more mortality, more deaths within this population. So at AXA Emerging Customer, and I remember where I was sitting in Spain at the time, and one of my colleagues in Thailand rang me and she said, you know, all that stuff we were going to do with financial inclusion and healthcare, well, the pandemic's going to put a stop to that. And I said, absolutely not. It's not. This is the time to finally open that digital front door to healthcare. And that's what happened. We created 8 COVID clinics in 8 different countries. We bundled it with insurance, no-cost insurance to protect those most at risk so that if they did fall ill, they had some critical illness cover, they had some hospital cash cover, very simple insurance products. But we put at the front end the access to standardized medicine, standardized advised by a doctor, a general practitioner, a primary care physician who could deal with the symptoms as they arose and give the right direction of travel. And this kind of, it snowballed. We went from India, China, to Brazil and Mexico, Egypt, Indonesia and Thailand. And we created these 8 amazing COVID clinics with partners who were already telehealth providers, and AXA bundled their insurance with it. We've reached over 1.5 million customers and consumers since, and reached so many people that could have fallen into poverty. Just one quick example, if I may, has been in Egypt, where we had a huge success. And I'd just like to give you a little example of that. We bundled our insurance and we partnered with microinsurance, with micro lenders, micro banks in MFIs in Alexandria, 4 or 5 of them. mostly people that borrow from these kind of microfinance institutes are small SMEs, people that have tiny little businesses. They borrow between $30 and $50. And if that wage earner, the person who's running that business, falls sick, they'll fall behind with their loans as well. And we needed to keep that economy alive as well. So in partnership with the MFIs and a very good telehealth provider, we set up almost like an online, offline digital service for standardized medical advice. We bundled that with hospital cash and critical illness cover. And we reached many, many people who otherwise might have defaulted on their loans. So it was a double win. We won on both economic inclusion, financial inclusion, as well as health inclusion. So really interesting stories to tell across the world in many, many countries that AXA have supported.
That's really impressive and heartwarming. And from what you've seen, has the COVID pandemic reinforced existing trends, or have you seen new trends emerge?
Well, I mean, the existing trends we see are really on deepening the health inequalities. So when you're poor, you've got not proper access to healthcare, and then somebody tells you you've got to social distance and wash your hands, and you don't have running water and you don't have any soap. What on earth are you supposed to do? So it's really deepened the inequalities, I believe, in standardized healthcare. And then you'll find that people were sick, they were sicker, they couldn't access services. So even in rich countries, France, Germany, UK, places where UK where I work, in inner city Birmingham where I work, a lot of elective care got postponed because people were terrified of going to the hospital, because that's where COVID was. So we found that sicker people became sicker, and that was that's a trend that we've seen. But on the bright side, what we've seen, some of the trends are that the digital front door to healthcare is finally open. I've been wittering about it for 17 years, but here we are now. It's finally open. That horse has now left the stable. And people are walking through that door. I think it's only a good thing that people have more access, the more standardized access to healthcare, and it's improved the way people have accessed healthcare. And I believe that's here to stay. Of course, we'll find some of it reverting to face-to-face. People still want to see their doctor face-to-face. They don't always just want the digital experience, but it really has changed the way that healthcare will deliver for the future.
Well, thank you so much for that, Niti. We'll come back to you a bit later. Perhaps the main takeaway from what you've been telling us, the question of accessibility and affordability of healthcare is obviously at the heart of the patient experience. For more on that, let's turn now to Dr. Kanta, who's head of programs for Cameroon, Niger, DRC and Chad at ALIMA. That's the Alliance for International Medical Action, whose model of governance is based on local NGOs. In other words, a network of partner organizations, so as to increase the impact of their medical emergency programs, especially in areas of conflict with high mortality rates. Kanta, thank you again so much for being with us. Now, you operate in countries plagued by recurring epidemics, of floods and wars, where communities are often isolated. So how do you adapt to that? How does ALIMA's model work to bring healthcare to those specific people?
Yeah, so ALIMA is an international medical NGO, and we work in some insecure areas, in some hard countries, as you said, so with conflict, epidemics, and etc. And so we are bringing medical assistance for this community and crisis to people who are in need. So monthly, women and children, because they are the main part of this population who are in the country. So we are trying to manage and to save lives in these kind of countries. And in these kind of countries, the Ministry of Health mostly is weak or non-functional. So we are trying to give people to try to we are trying to save their lives because the health centers are not functional or they are weak. So sometimes people need to walk many kilometers to come to healthcare center. So for us, the goal is to bring access to this for health services, to provide outpatient and inpatient care and nutritional activities mainly. So for sure, to respond to some epidemics as epidemic measures, meningitis or cholera. And as you said, for epidemics as COVID-19 and Ebola outbreak, something. So these are the responses that we are trying to bring to community in crisis. At the same time, we are trying to support the health system if possible, for sure. And because in some contexts, maybe the health system are not functioning, as I said. And then in those countries where the health system is functioning, we're trying to work to strengthen the system and to allow local staff, health workers, to implement the activities, even if Alima is going. So this is the key intervention that we are meaning and the philosophy of our activities. And many local staff or many local workers need to be trained also, because they are not really trained for the first training in the university or the school, health school. So we need to coach them and to support them for these medical activities, tools and protocols. So these are not most of the time available in this context where we are working. And so our philosophy or one of our activities is to bring these tools and protocols and to make a kind of training for this health staff, ministry health staff. And it means that we are trying to make a kind of capacity building for this local staff. And another thing that we are doing is, in terms of activities, is yes, we are trying to, the main objective for us is to reduce the mortality rate in these countries, and then to ensure to increase the rate of curate part of the patients. These are some key indicators that we are trying to follow up during our activities. And another element with Alima is to work together with local staff. And as you said, I think most of our staff are coming from these countries. And I can tell you that around 98% of the people where we're working are coming from these countries where we are intervening. So, and this is to allow us, this can allow us to be close of the people as much as possible. And it is a kind of, we are trying to create a kind of acceptance, access, and trust with this community. It also allows us for a kind of a quicker response in times. So it means that I can give you the example of COVID-19, where this epidemic started, all the countries have closed their border. And due to our staff who are local staff, so we try to respond to this outbreak with our local staff, with our local partners. So this is a kind of a model of intervention that we are conducting now. We should continue this model as much as possible, because it is something which is important to these countries in crisis. We want to discuss with partners, because the key point is for us is to continue to discuss with local partners with the what can I say, the impartiality part. It is something that it's not negotiated for us. We try to give them the impartiality during our assistance, meaning that we cannot make any discrimination during our intervention. So these are some key elements that we are trying to discuss with our local partners before starting working together. And it is a key point that yes, we cannot negotiate on that. So Alima also is conducting some research and innovation, which is a part of the, I can say it is a heart of our activities. So we are trying to carrying innovation. I can give you the example of MOAC, which is a program of training mother. The MOAC is mean that the mid-upper arm circumference, which is used usually by health workers. Or yes, so the point is we have tried to show that mother can do these activities, and it was shown that mother could use this tool at the same level of knowledge compared to the health workers. And then, yes, this is one key innovation that we have conducted in Niger, and then this tool have been used now by many countries as Niger, Chad, Cameroon, and they are trying also to put it in their national protocols. So this is a kind of innovation that we have conducting. And I can give you an example of around for these 4 countries that we have mentioned, we have done around 200,000, what can I say, mother who have used it per year, this kind of tool. So this is our data for 2020, for example. It means that we need to continue to involve patients, to involve community in this kind of activities, mostly for the nutrition part, for example. I can give one anecdote for a woman, a mother who has 6 children in Niger. And this mother said that, okay, with this mom, she's living far away from a health center. So she have to do another half, what can I say, homework before going to the health center. So with the mom, she is trying to screen her 6 children as much as possible. If she need to do this more at the day, or I don't know, depending on the need, she have used this tool, and she have screened her children who are some and went to the health center without any pressure, and by doing all her homework, and then she have organized herself by using this tool, and then she was very happy, saying that okay, she felt that she is a part of this treatment of her own children. So this is a kind of anecdote that we have received from a mother in Niger. And then from just that time, this mother started to, I don't know, to involve, to train the other mother in the community by using the same tool in the village.
It's clearly a positive cycle. Thank you very much for that explanation, Kanta. That sounds like challenging but fulfilling work. And you mentioned innovation there. I'll have another question for you a little bit later, Kanta. But first, I'd like to cross to Dr. Serap Aksu on that issue of reaching isolated communities. Dr. Aksu is an AXA Research Fund grantee from Koç University in Istanbul, who's developing an easy-to-use, innovative portable device to detect cervical cancer for women in rural areas. Serap, could you please tell us more about that particular project?
Yeah, sure. I will try to reflect an engineering perspective to problem of bridging the gaps in healthcare access. So first, let me define the problems that we perceive. So accessing healthcare in rural areas is generally problematic. Geographic limitations aside, this is mostly due to the fact that there is a lack of medical equipment investment, or there is a lack of personnel specialist involvement in those regions. So we are aware that actually for early diagnosis of diseases, regular testing for certain biomarkers or imaging is a must. So there are traditional methods for biomarker testing that are accepted as a gold standard in medicine, such as like PCRs, ELISAs. But most of those tests require a specialist who can implement sensitive procedures for biomarkers in the blood or in the body. So in addition to the need of specialists, we need a huge investment on the laboratory equipments that are needed for accurate and reliable medical tests. Thus, the lack of such investments are the main reason for limited healthcare access in rural regions. On the other hand, one important barrier for healthcare access is the poverty. So for underprivileged communities, even very standard tests, like medical tests, like the blood sugar test or PEP test for cervical cancer screening could be problematic. Even though these tests are very standard in daily life now, I mean, people could be hesitant to go to a clinic just because of the high clinical costs. So apart from those two problems, now pandemic has taught us new challenges. So we experienced actually the healthcare conditions in rural regions actually in a major state. So we learned that actually healthcare is not for granted. Even the populations that live in a city may not have access to the healthcare properly. So hospital access could be limited, or the fear of virus prevented patients to go to the clinics and hospitals. So therefore, the routine tests could not be implemented on patients, and linked to this, the efficacy of remedial therapies could not be followed, and the therapies could go to waste, or people lose the chance of early diagnosis. So in short, we learned that the point of care devices, in other words, bedside testing devices, are an important need in daily life. So the objective of a point of care diagnostics is to generate portable devices that can be readily employed by an end user. He or she could be a patient, and provide highly accurate and reliable testing. So in summary, there are three challenges we need to overcome. So lack of equipment and personnel investment in rural areas, the high cost of visiting a clinic, and the need of test kits experienced especially during the pandemic, not only for virus, but also for other biomarkers for cancer or other genetic diseases. So there is a simple solution to these challenges, actually. So we need to generate a low-cost, small and portable testing platforms, such as this one. I want to show you this. That could be applied for a wide range of disease testing. So towards this end, we work on so-called photonic biosensors that do not use conventional methods of biodetection. So the sensors we are generating are basically metallic, and they are nano-sized structures, and they do not have a limited shelf life. These sensors have interesting optical properties, so this is why they are not only used in biomedicine, but they are also used in a variety of different sectors, like ranging from energy, defense, and they also find wide usage in biomedical applications. By simply shining a light, we could observe a change on the sensor and decide whether the target biomolecule is in the sample or not. So unlike conventional medical approaches, putting the sample on the sensor surface or reading out the results do not require a specialist or any other bulky machinery or clinics. So anyone can basically run the tests. So in addition, when compared to the material cost of the standard biomedical techniques, the cost of sensor is too low. Basically, you can expect a cost of like a couple of euros as a production cost of a ready-to-use sensor. So in short, the ease of use and the lower production cost for photonic biosensors can potentially enable more accessible healthcare. So in particular to my project, so as an AXA Research Fund Fellow, I specifically chose the study on human papillomavirus, HPV, which is the cause of the cervical cancer, and apply the HPV on those portable platforms, basically. So the bad type of HPV DNA can cause various cancers on both men and women. However, the death toll for women is statistically higher. So current estimates actually indicate that every year in Europe only, about like 60,000 women are diagnosed with cervical cancer, and about like 24,000 of them die from the disease in Europe, where healthcare is relatively more accessible. So for males, the death number is around like 11,000 due to the HPV-related cancers on throat or on any other parts, which is still not low. Even though the numbers for male death is not low, the history of HPV vaccines development and implementation has been specifically focused on the females due to its initial testing on cervical cancer. So that resulted in somehow feminization of the disease and introduced gender biases. So feminization has potential to negatively impact the public awareness. Now, people could perceive it as if like half of the population is under threat, male are not affected, but this is not actually true. So we show that these point-of-care test devices that uses the photonic biosensors allow specific and rapid determination of HPV analyte, not only in the lab, but in the places where regular medical tests such as ELISA or PCR cannot be performed. So this will particularly improve the early cancer diagnostics rates in low-resource populations and also in like major cities where a complete medical infrastructure is missing or not reachable. So I think the importance of the diagnostic tools are now better understood thanks to the pandemic. And healthcare providers actually will be more open-minded for implementing and using the next generation of technologies such as photonic biosensors at the end.
Well, thank you, Serap, for that. This innovation of yours sounds like a real game changer in the early and therefore effective detection of what is a very serious disease. That takes us to the key issue of qualitative care. Kantar, let me come back to you on that. Could you please tell us more about how you ensure that quality care is brought to people in a sustainable manner?
Yeah. So, thank you. As I explained for an ALIMA model, I can continue by saying that for the example of outbreak, following the lesson learned from Ebola 2014-2016, ALIMA developed a cube. It is an individual intensive care unit. So to take care for Ebola patients because without cube, as you know, families can't come to see the sick people. And so the cube was a kind of tool who allows patient and family to be in touch without fear of contamination, and it is used in DRC and Guinea, for example. So it is also this cube is also reduces the risk of contamination for health workers by allowing health workers to care the patient from the exterior of the cube. So this is a key innovation also in according to the outbreak management. Second thing is in terms of capacity building for health staff. So, for example, in countries as Mali, Chad, we have trainings in an integrated school in the hospital, some health worker who how to care some with malnourished with medical complication. So these experiences have been conducted in these two countries, and children suffering from severe acute malnutrition who require, as you know, specialized care from medical staff. So, and we know, as I said, the MOH medical staff are not trained well. So we are trying to build their capacity, and from that, many local medical staff have been trained. And before the training, we are trying to make a kind of assessment, and the assessment or the evaluation had made that most of these medical staff do not know how to cure malnutrition with medical complication. And I can give you the example of the Mali. Only around 30% of people know how to cure severe acute malnutrition with medical complication before the training. And then after that, the training, we have seen that the knowledge is going up around 80-90%. So these are some key examples that we have using. And another example is in DRC, Central African Republic, where we are trying to make the same training, but for the maternal and reproductive health, meaning that this training was done for what they call it, the midwives and the traditional birthing assistant, and the same, for sure, the same outcome or result have been shown there. So for us, strengthening local competencies and expertises, make our program sustainable, because even if ALIMA is not there, so the local staff, local medical staff could continue to, and they could be able to continue to provide good quality care for this population in crisis. So these are some key examples that I can share with you. Yes, for sure. And the more that I have explained before, another innovation that we are trying to conduct according to this context, which are very, very difficult for us.
Absolutely, and it's interesting how you empower people on the ground. Now, obviously, when we talk of healthcare, a number of different actors play a role in providing access to healthcare. Among those are, of course, insurers. And on that note, I'm pleased to welcome back Wesley Dukalski, who's the CEO of Sendero Health. Now, that's a not-for-profit, community-based, county-sponsored health plan that provides Affordable Care Act compliant health insurance policies in Central Texas. Hello again, Wesley.
Hello.
Now, we're traveling from middle-income countries or low-income countries to low-income communities in the developed world with you. The US is certainly a complex market. So how does an insurer like yourself make sure that access to qualitative care remains a priority when patients simply can't afford it?
So complex was the key word. I think most people may have heard of the Affordable Care Act, which was the largest reform of healthcare, largest Healthcare Legislation Reform Act in the states since the original Medicare and Medicaid Act in the 60s. And thankfully, the ACA was successful in reducing the uninsured by at least 20 million. Unfortunately, because of the complexity of the system in the US, it still left about 30 million adults uninsured. Even in a relatively prosperous area like Austin, that directly translates to about a few 100,000 people, or well over 200,000 people, low-income individuals, without access to coverage. And in the States, without a payer or without an ability to pay for care, you have severely restricted access to care, basically only emergent care. So Sendero was started as a 501c3 by the county to address this challenge of indigent care. Care that providers did try to provide to local physicians and hospitals when they would try to care for people, their options for reimbursement were pretty limited to some restricted funding sources and basically a complex patchwork of government programs. So what we've been able to do over the years is develop a program that specifically targets the most challenging of these people, most disadvantaged, lowest income, and the most serious illnesses, and match them up with a full coverage policy, which enabled them for the first time, many of them for the first time in their lives, to get full care. And this had two effects. I mean, not just transformative effects for the individual, but significant effects for the county, who now suddenly was relieved of much of the uncertainty of the burden of caring for these people and negotiations and so for providers. So basically a win-win all around. The members get care, the providers get paid, and the county is relieved of a significant burden. This program generally translates into about at least a doubling of available funding for care. AXA's role is pretty critical in this. So for insurance, the challenge is paying the bills, the underwriting. And since this required a lot of pretty forward underwriting, this would not be possible at all without AXA's very forward thinking and partnering on exactly that, on the underwriting.
And can you tell us a bit more about indigent coverage?
So indigent coverage is a misnomer because there's basically minimal to no coverage for indigents. If you are uninsured, you can get emergent care, and through your local FQ, through your local clinics, you can get basic primary care. But if you have any kind of serious illness, that advanced care, for specialists, facilities, transplants, cancer treatments, just down the list, anything complex, you are pretty much relying on the mercy of the system to try and figure out a way to deliver that care to you because it's unreimbursed and unpaid for.
Well, thank you for that overview, Wesley. You certainly have your work cut out for you over there. Now, as we've just heard, healthcare in the United States has its own specific characteristics, obviously. But having said that, the question of universal coverage is key for any country, be it high, middle, or low income. And private actors have, of course, understood the issues at stake, as Wesley was telling us a bit earlier. The health crisis we're going through is once more, obviously, a catalyst in accelerating the synergies between public and private actors in different sectors, from delivering vaccines in record time, as we've been trying to get here in Europe, to reorienting production lines as a collective effort. So let's shift now to the perspective and expertise of a reinsurer. Elena is in charge of public-private partnerships at AXA. Hello again, Elena. I'm curious about the role of insurers. How can they support public-private partnerships?
Hello, thank you. Definitely there is a substantial role to be played by the insurer, and as shared during that discussions, they were giving real case examples, and definitely COVID-19 put into evidence that public-private partnerships are a necessity when governments need a full range of services and expertise. This is particularly true when the problematic to solve demands innovative alternatives in a particularly rapidly changing environment. And that's typically the case when we talk about and when the governments try or implement universal health cover. So developing countries have done significant efforts over the past decades in increasing the access to healthcare. Many governments have set quite ambitious targets in reaching, in implementing universal health cover. But it is a matter of fact that although health budgets continuously increasing, resources remain scarce, and political priorities need to be set up and efficiencies to be gained. Therefore, planning well and implementing efficiently, it's crucial, and it requires a holistic view and expertise and skills. So this is why typically combining public and private sectors help to balance help to balance and to reach and to be beneficial. And it's definitely it's important to align interests and objectives, and roles has to be clearly set up in advance and in full transparency. That's really crucial. So historical models with quite centralized, exclusive state management, they're quite very difficult to apply in developing countries where up to 90% of the population is informal. So this can hardly work. But combining in a kind of hybrid models, expertise, state expertise and insurers expertise, then definitely this equation can be quite very very effective indeed. So, and this is quite crucial to reach and to promote efficiency, to ensure sustainability, and to improve, of course, quality of care. Indeed, there are few words that are quite very important: efficiency, once again, and sustainability. Because if we build public health system which is not sustainable, it could be disastrous. So definitely insurers can play a substantial role in helping the governments to run efficiently, to build and to run efficiently a system. But as I said, it's a joint collaboration. So here the governments are expected, and they can play a crucial role in setting up the regulatory framework. Governments are offering the health infrastructure, and of course governments are monitoring the entire health system. Insurers are they play a vital role in all of this, once again, to promote to gain in efficiencies, but they are also bringing quite important visibility in terms of budget planning. And this is possible by transferring the risk from the state to insurers, and that is typically important in a very unknown environment. When we build social security, there are many uncertainties, and dealing with that, it's quite tricky. Having in mind that we have to budget the final cost. So, for insurers, once again, insurers can play a substantial role, and how it's possible? It's possible by participating throughout the entire chain value, and which means leveraging technologies, new technologies, make the health budget more predictable, and by cost containing as well, and also at the end it gives also clear visibility to the authorities, helping them for better planning, healthcare planning. So I would say the public-private partnership can play here a very virtuous circle by attracting private investments, which helps once again to promote, to improve standards.
That's wonderful. Niti, let me jump back to you on this. You mentioned advising governments. Can I ask, what do governments expect from private players?
Well, it's very interesting. And I helped co-author a piece of thought leadership on this called The Triple Win with my KPMG hat on. So exactly as Eleanor said, I mean, she's outlined very clearly the benefits. So it's maximum benefit for limited public capital. There isn't a whole amount of capital floating about. For patients and public, higher quality health services at same or less cost. Again, Eleanor has alluded to that. And for private players, a sustainable return on their investment and expertise. But, and that's kind of the triple win that governments will get. However, that we found in many, many countries around the world, I've been around in circles on this one, you can select the wrong kind of priorities for projects for PPPs. And really focusing on universal healthcare, as Eleanor has outlined, is really important, but its funding should be free. So that's the basic tenet of this. The second thing is, so whoever provides that, whoever the payer is, whoever does the actual nuts and bolts is quite different from actually funding the system. Then governments setting objectives that incentivize a narrow focus rather than high value healthcare. Choosing the wrong partners to work with, so you can work with the wrong partners, and making restrictive assumptions about the future. So, you know, what the future looks like, we've seen the pandemic has kind of done that. And then failing to generate sufficient competition and contestability around this. So again, so many governments can take too narrow a focus around this. The other thing that I just like to point out on kind of the PPP story, as Eleanor has very elegantly outlined all the risks and the opportunities, I worked quite closely with the largest healthcare reform in the world has ever seen, and that's Ayushman Bharat in India, where I'm currently based. This is Mr. Modi's grand plan on Modi Care. It's ensuring 500 million people. It is really the largest healthcare reform that I've had a chance to see. And they've ensured, I mean, they've provided access, a really good cover. The premium is low, the cover is great. But I think what's been missing is primary healthcare. So if you allow access to healthcare, like very hospital-centered care, and that's what you're funding, and don't fund the primary care bit of it, which is your gatekeeper, your foundation for population health management, you can end up in a lot of trouble in terms of your public budget. And I think the Indian government is starting to address that very quickly. And the pandemic has kind of accelerated that. And I think your other panelists also spoke about that community grassroots engagement, that primary care engagement, the gatekeeper role, really important in keeping cost controls and efficiency. I mean, primary healthcare is 80% more efficient than a hospital-based setting. I would say that. I'm a primary care doctor, so I would say it. But those are the sorts of things that the governments need to pay attention to if you're really looking at PPPs. But the simple story still is governments have to fund it. That out-of-pocket should come in, co-payment should come in much, much, much later. And hearing you speak from the US, I mean, that's been a part of the problem, right? We get hung up on co-payments. Who's going to pay what, rather than actually starting to look at the system as a whole and free at the point of access. So I'll stop there for any more comments, Nadia. Happy to jump in.
Well, have you seen sort of public-private partnerships that really expanded healthcare access to disadvantaged populations?
So I'm seeing that across the world on the provider side. So very much so in Indonesia, we saw that with Mr. Jokowi's reforms. We saw a huge public-private partnership expansion of public hospitals. We've seen that in Southeast Asia and many, many countries. So we're seeing that on the provider side. On the payer side, the US is probably your best example of some public-private partnerships. But we had a very interesting story. I have a very interesting story to tell from Bangladesh, where I worked with a telco to set up the largest healthcare provider business, digital healthcare provider business that's serving 7.8 million people now. From a standing start, so it's insurance bundled with digital access, it's providing care management programs, the lot. It's a really interesting platform-based business, and it costs, guess what, between $15 and $17 a head a year to offer 24/7 access to healthcare. So there are some very interesting stories that are emerging. Bangladesh government has looked at it and has said, well, can we use this as the basis for providing primary care access to underserved communities? Bangladesh is a big country, lots of people, and very disparate access, very remote and rural areas as well. And how could you do that? So I think many governments are waking up the fact that actually the public-private partnership may be with different sorts of people, micro-insurers, with telcos, with distributors. We're working with very interesting distributors across the world in AXA. So I think this space is evolving as we speak, and watch it, because I think governments will start to look at a very different kind of partner for providing PPPs in the future.
Elena, do you want to jump in on that?
What I would just say is, from insurance perspective, is this kind of public-private partnerships gives, I mean, the direct outcome is to reach a very large-scale schemes. That's the direct impact. But then, because it helps to improve the entire well-being and improve standards, at the end, the indirect impact would be it increased awareness for insurance. So definitely there is an interest for the insurance industry as well.
It's win-win.
Yes, absolutely.
Well, unfortunately, that's all we have time for today. Thank you so much to you, Elena, and to our four other panelists for sharing your insights with the teams today. It's so helpful and I think inspiring to get a wider international, multidimensional take on all this, and also benefiting from such a variety of views, personal views on the ground of what's going on and perspectives on that situation. As we've been hearing, innovation is clearly key in approaching healthcare from a technological standpoint, obviously, but also as a new approach to humanitarian initiatives, or even business models, in fact. Prevention is also an essential tool in ensuring better monitoring of health risks. And as our guests have demonstrated, it's essential that governments support healthcare access initiatives, ideally with that long-term policy to deliver free care for all. In this sense, public and private partnerships can certainly enable efficient healthcare access. Well, on those takeaways, it's time to wrap up this talk. Thank you again to our guests. Thank you for having joined us and having listened in. We hope that sparked some interest for you, and will also spark debate among AXA teams. Thank you for watching, and goodbye.